Um, so today my talk is going to be about acute liver injury and acute liver failure. So whenever you look at the two topics, one leads to the other. So I'm going to speak mainly about acute liver failure in the stroke. So if you look in the American Association of Study of Liver Disease, the diagnosis of acute liver failure consists of severe acute liver injury, encephalopathy, and coagulopathy characterized by INR more than 1.5. And all of this happened within 26 weeks with no obvious history of underlying liver disease. The same definition goes to EASL guidelines, which is the European Study of Liver Disease. So if you look at this, acute liver failure consists of the same severe acute liver injury, where there is no underlying chronic liver disease, there is a liver damage, the serum aminotransferase is 2 to 3 upper than normal limits. And there is impaired liver function test characterized by jaundice and coagulopathy. And if this patient within 12 weeks post-jaundice develop hepatic encephalopathy, then we call it acute liver failure. So the etiology of acute liver failure is anything that can cause acute liver injury, which consists of, as all of you know, viral drugs, toxins like mushroom toxin, pregnancy, vascular disease, and some others, which we're gonna come across. If you look at this, this is the worldwide causes of acute liver failure. Let's take Bangladesh as an example. You will find there the majority of acute liver failure is due to hepatitis E virus. The same happens in India, where in Japan, the majority is due to hepatitis B virus. If you go to Europe and US, the majority is due to drugs, mainly acetaminophen. Again, this is the etiology based on geography, where you can see the same thing across the globe. There is subclassification of acute liver failure, and there is different grades or classification. So this is, I would say, the main classification we all use. So if the patient develop hepatic encephalopathy within a week from the acute liver injury, this will be an hyperacute. If it takes 1 to 4 weeks, this is an acute. And if it's take 4 to 12 weeks, this is a subacute. And usually the prognosis is good in hyperacute, while it's poor in subacute causes. So the commonest cause in the Western region is due to acetaminophen toxicity. As all of us knows, the recommended maximum dose is 4 grams. And the bulk of acetaminophen metabolism involve formation of non-toxic sulfate conjugate, which are excreted in the urine. About 10% form a toxic metabolites that is capable of producing oxidant cell injury. So the toxic metabolite is removed by conjugation with glutathione, which is an intercellular antioxidant. So when the glutathione depleted, this will lead to liver toxicity. So hepatotoxicity usually develops in 1 to 2 days after the overdose, and the ALT and INR peaks around day 3. And as of all of us knows, the N-acetylcysteine is the proper antidote. if you look at the percentage of people who develop acute liver failure, you will see that only 0.1% happens in hepatitis A virus. Well, it goes up in hepatitis B virus to 1%. If a pregnant lady have hepatitis E virus, 20% she will go into acute liver failure. So the main causes of acute liver failure in pregnancy compose of two, which is HELP and acute fatty liver pregnancy. So HELP, as all of us knows, hemolysis, elevated liver enzymes, and low platelet, where acute fatty liver pregnancy characterized of extensive hepatic steatosis and usually present with abdominal pain and malaise. Hypoglycemia is common there, where the transaminases is relatively low. And if a pregnant develop acute fatty liver pregnancy, the mortality is quite high as 20%. So the treatment of both is delivery. And emergency transplant is rarely needed in these cases. So what are the clinical features of acute liver failure? So acute liver failure affects various organs in the body, and ranging from the brain, from head down to toe. Where in the brain, hepatic encephalopathy is the most common clinical features. If you go to the liver, so liver loss of metabolic function, which decrease. That's why patients with acute liver failure develop hypoglycemia. And when there is effect in lactate clearance, that's why they have lactic acidosis. And when the ammonia clearance is affected, that's why they develop hyperammonemia. So clinical stages of acute encephalopathy based on West Haven criteria, which all of us knows, there is 4 grades of hepatic encephalopathy. Grade 1, where there is lack of awareness. When the patient started to develop agitation, lethargy, and seizure, that's grade 2. And when the patient arousable only to pain, that goes to grade 3. When he's unarousable at all, this is grade 4. So how do we manage these? So I'm going to speak about the guidelines in how to manage acute liver failure, and mainly I'm going to use the European liver study guidelines. So whenever you come across these patients where they have the main characterization of acute liver failure, the liver injury, coagulopathy, and encephalopathy, this is how you should manage them. So immediate measure, you exclude cirrhosis, alcohol-induced liver injury, or malignant infiltration. And we will come across why we are doing these in the next slides. So how do you assess these patients? So because the clinical picture and radiological features of subacute liver failure can mimic cirrhosis, these patients should have an immediate radiological assessments of their liver upon presentation. In patient with acute liver failure, liver biopsy has limited role, except in patient where there is an underlying liver disease, malignancy, or alcohol-induced liver disease is there. And whenever you come across a patient with acute liver failure, immediately you should start discussing transferring this patient with a liver transplant center, even if they will not end up there. So always, whenever you come across these patients, determine the etiology to guide your treatment. Especially, it will guide your treatment if these patients need liver transplant. The patient develop acute liver failure due to drug, acute viral, toxin, bad Chiari, autoimmune, pregnancy. These are the patients who will be candidate for transplant. If the patient develop acute liver failure due to hypoxic hepatitis, systemic disease like infiltrative disease, lymphoma, infection, these patients, there is no indication for emergency transplant. If you see here, they mentioned acute hepatitis in the category where there is no indication for emergency transplant. But ultimately, these patients, if they progress to liver failure, they might ended up doing a transplant. So differential diagnosis based on clinical features. Patient with paracetamol overdose, you're going to see thousands of the ALT and ALT in thousands mainly. With a low level of bilirubin and rapid progression of disease. There is usually a renal impairment and acidosis. In a patient with non-paracetamol drugs, their clinical course is usually subacute. If you see a patient with bad Chiari, as they will present with abdominal pain, ascites, and hepatomegaly. Wilson disease, you always see it in young patient with Coombs negative hemolytic anemia and high bilirubin to alkaline phosphatase ratio. Mushroom poisoning, the patient will present with severe gastrointestinal symptoms, and they're gonna develop an acute kidney injury. Autoimmune usually present with subacute presentation. You might found some positive antibodies, elevated globulin, and these patients will benefit from liver biopsy. Acute ischemic injury, they present with ALT and AST in thousands with increased lactic dehydrogenase and creatinine, but usually they improve with the time. So what if the acute liver failure is due to malignant infiltration? So malignant infiltration of the liver and acute ischemic liver injury are not indication, as I mentioned before, for transplant. And you should exclude these in patient, especially you're gonna find history of cancer, or you're gonna find a hepatomegaly in patients with non-solid malignancies. And sometimes you need to do a liver biopsy to confirm that. Acute ischemic injury, usually these patients, they improve with the supportive measurements and if they are hemodynamically stable. So drug-induced liver injury is the most common frequent causes of severe acute liver injury and acute liver failure. And the mainly, as we mentioned before, is paracetamol. At admission, a toxicology screen and determination of paracetamol are necessary in every patient who presented with acute liver injury. And you should start them immediately on N-acetylcysteine therapy. Prognosis is worse in patients who with staggered ingestion. So if they take the paracetamol over time rather than one ingestion. Acute liver failure caused by non-paracetamol drug-induced hepatotoxicity is always a diagnosis of exclusion. What about in patient with viral and autoimmune acute liver failure? As we mentioned, it depends on the country, but worldwide, hepatitis B virus is the commonest. and existing of other autoimmune condition should raise the suspicion of autoimmune hepatitis also in these patients. Always screen for viral etiology. If you suspect an autoimmune etiology, do a liver biopsy. But if the patient develop acute liver failure that necessitate an emergency transplant, don't wait for the biopsy. So what about other uncommon etiologies? In most cases, a potential positive effect of specific intervention will be too late to be beneficial. Always, emergent liver transplant should be considered and not delayed. So always assess in the clinical context of presentation. Acute Budd-Chiari syndrome should be suspect in acute liver failure presenting with acute ascites. Again, Wilson disease should be suspected in Combs-negative hemolytic anemia with high bilirubin to alkaline phosphatase ratio. In cases of HELP and acute fatty liver of pregnancy, the treatment of choice is prompt delivery. Always screen for systemic disease in patients who are presenting with acute liver failure. So how do you manage these patients? So there is a management outside of ICU and there is a management inside of ICU. I will go quickly across them. As we mentioned, assess disease severity, check for the etiology, and test for complications. So do the diagnosis, monitoring, diagnostic culture, chest X-ray, ECG, routine monitoring of oxygen saturation, standard care in all the patients with glucose infusion, stress ulcer prophylaxis, and acetylcysteine. Try always to avoid sedative and avoid hepatotoxic and nephrotoxic medications. This is the criteria, the King's College criteria for patients who need a liver transplant in paracetamol and non-paracetamol. Transfer patient to specialized unit early as possible. The diagnosis of acute liver failure should be considered with respect to full clinical pictures. Always involve a senior to manage these patients. Hourly urine should be done in these patients. Clinical deterioration and extrahepatic organ involvement should result in transfer to critical transplant centers. These are the main organs which are involved in acute liver failure. You have to manage cardiovascular if the patient is hypotensive. The main drug of choice is noradrenaline after proper crystalloid resuscitation. Respiratory management, standard sedation, and lung protective ventilation should be used in patients with acute liver failure. Avoid excessive hyper and hypocapnia. Gastrointestinal, you have to make sure these patients are fed well. Always consider parenteral or enteral feeding whenever it's necessary. There is a mentioned word here in the guidelines, avoid nasogastric tube in patient with progressive encephalopathy, which is strange to us. Because whenever we come across a patient with hepatic encephalopathy progressive, we put an NG tube to feed them. The idea of this is these patients might develop delay gastric empty, and they will develop a microaspiration with the time. So in these patients, you may consider post-pyrolytic feeding with nasojejunal tube. Monitor ammonia always. PPI should be considered in the context of ventilator-associated pneumonia. Consider stopping PPI once enteral feeding started. What about metabolic? These patients always develop hypoglycemia and hyponatremia, and you should manage that accordingly. Acute kidney injury and renal replacement therapy, 40 to 80% of acute liver failure will have an acute kidney injury. and they should manage them. Sorry, just 2 minutes and I will finish. Okay. So always manage them appropriately in coordination with the nephrologist. Extracorporeal support RRT are needed in these patients. Anticoagulation is still debatable in these patients. Continuous RRT should be undertaken rather than intermittent hemodialysis. Remember, these patients present with coagulopathy. So most patient coagulation is normal despite abnormal INR and PT. Again, most patient coagulation is normal despite normal INR and PT. And that the routine use of FFP and other coagulation factor is not supported and should be limited to specific situation where you need to monitor intracranial hypertension. The target hemoglobin is 7, and always give these patients venous thrombosis prophylaxis, even if their INR is high or if you see a coagulopathy in them. You have to manage systemic inflammation, use antibiotic in appropriate contexts, in a prolonged critical care support with multi-organ failure, antifungal can be considered. So hepatic encephalopathy should be managed appropriately with, I think all of us knows how to manage hepatic encephalopathy. Whenever a patient goes to grade 3 hepatic encephalopathy, intubate these patients. Monitor intracranial pressure. Patient with low-grade encephalopathy should be frequently evaluated. 10 seconds.
We can put that back, the final slide.
Yes. Okay. So in patient with grade 3 and 4 encephalopathy, intubation should be undertaken, and transcranial Doppler is a useful non-invasive monitoring. So what about artificial and bioartificial liver devices? I mean, the study behind them is not is somehow disappointing. Plasma exchange has shown to improve transplant-free survival in patients with acute liver failure and to modulate immune dysfunction. Impact of liver transplantation, you can see the improvement of these patients with the time. The year after survival has improved dramatically. And again, this is the criteria for emergency liver transplant using King's and Clichy criteria. Evaluation of prognostic factors should be taken in these patients. So assessment for patient with acute liver failure for emergency require input from multidisciplinary team with appropriate exposure. Patient with acute liver failure and potentially they will deteriorate and they will be a candidate for liver transplant should be transferred as soon as possible to a specialist center. And they are the highest priority for donated organs. Irreversible brain injury is contraindication in these patients. Patient transplanted for acute hepatitis B needs ongoing suppression therapy. And thank you.